So we are so honored today to have such an elite group of neuroimmunologists here for our panel discussion on the different disorders that you've just heard about. And I'm going to say, sort of any aspect of care related to that. I'll have our panelists introduce themselves once we get settled. And I will say that this afternoon we'll be discussing symptomatic treatment. So we'll talk more about pain, we'll talk about autonomic symptoms. And Dr. Schofield, if you'd like to join us for the panel as well, that would be great. And then we have rehabilitation, Janet Dean. Janet, you're on the panel as well. Come on down. So we will be addressing several of the aspects of care in more depth throughout the day. But this is an opportunity to ask different questions of our panelists. I have a couple questions that I'm going to be posing to them as well to get their input. And we have Timmy and Aaron with microphones in the audience somewhere. And so if you have a question, please raise your hand. We will come to you with a microphone just so that we all can get the benefit of hearing your question. And then I'll ask the panelists as well to speak with the microphone so that we can all hear the answer. So as we get that set up, would anyone like to start the panel? Oh, no, wait, actually, I got ahead of myself, sir. Hold that thought. Let me have everybody introduce themselves. So your name, please, and what your specialty is. And Enrique, why don't we start with you?
Sure, Enrique Alvarez, and I'm one of the neuroimmunology docs on campus.
Siamac Esfandi. I'm a neuroimmunology fellow at University of Colorado.
Hi, I'm Sara. Is it on? Hi, I'm Sara Qureshi. I trained in neuroimmunology and multiple sclerosis at University of Texas Southwestern in Dallas. And now I'm practicing in Billings, Montana in the Billings Clinic.
Augusto Miravalle. I'm a neurologist and neuroimmunologist here in Colorado.
I'm Jeff Bennett, and if you don't remember that, we'll have a little discussion later on about the cognitive effects of this disorder. I'm a neurologist, neuro-ophthalmologist, and neuroimmunologist, and I practice here at the University of Colorado.
I'm Janet Dean. I'm a pediatric nurse practitioner at the International Center for Spinal Cord Injury in Baltimore, Maryland, and I'm going to be here talking about rehabilitation.
I'm Jill Schofield. I'm interested in autoimmune autonomic dysfunction.
All right. Thank you, everyone. Now, I think there was a question over there, sir, in the blue shirt. Okay, so it's a test. There's a red button on the bottom that you have to hit, and then you can press the... Oh, okay. Thanks, Alina.
Hello?
There you go.
Hi, I'm Dr. Mark Engelman from Phoenix, Arizona. I'm an internist in practicing functional medicine, but I've really gotten really turned on by immunology and immunological causes of not just this, but immunological causes of lots and lots of other things, and Alzheimer's disease and so forth and so on. So, and we do testing. I'm also a consultant for a testing company that does antibody testing called, well, anyhow, it doesn't matter what it's called.
Could you speak up just a little
bit? It doesn't
bit?
matter what it's called, but it's an immunological testing company. So one of the things that we test for is, food sensitivity testing is for aquaporin antibodies. And supposedly there's cross-reactivity between the aquaporins in spinach and tomato and soy. And you can actually test for those as antibodies to those. And supposedly there's a fair amount of cross-reactivity to those aquaporins and the aquaporins in the blood-brain barrier. So our recommendation is if someone has antibodies to those aquaporins that they stay off those foods. So do you have a comment about that in terms of obviously talking about aquaporins and autoantibodies to aquaporins?
Okay, well, I'm going to ask Dr. Bennett to comment on that in just a second, but say that the larger issue of, like, is there a right diet for me is being investigated in many different ways. But as of right now, there's no particular evidence for what we call an anti-inflammatory diet. But we can talk about the different aspects of diet and how they can affect health. Now, something as specific as whether or not a food can affect a certain water channel in the brain, I don't know that we have good evidence for that yet. But Dr. Bennett, I'll ask you to comment on whether or not you have heard of any research in that area.
Well, with regard to the issue of diet and immune disorders, very hot topic, but a little bit off of what we're talking about here. And if anyone wants to know, we can move that conversation further in terms of microbiome and how diet can affect microbiome and how microbiome influences your immune system. With regard to cross-reactivity between aquaporin 4 antibodies that cause disease in patients and other aquaporins, that is, water channels that are present in many different tissues and present in many different organisms, including the cells of things that we eat, there's actually no evidence whatsoever of cross-reactivity. That is, in terms of aquaporin 4 antibodies in our serum, those that cause disease, of which my laboratory was the first one to clone and use to make disease models, we've investigated to quite some extent that these are highly specific and conformationally, they're dependent on the absolutely folded structure of aquaporin 4. There are many other antibodies that are made by patients, including those that recognize fragments of other aquaporins and so forth that have nothing to do with the disease. And so I don't think that there is any concern that if you were to have Neuromyelitis optica, that by eating these foods that you would be having any difficulty, including causing any other abrupt immune activation. And antibodies themselves are not the issue in terms of the gut response. It's the cells within your body that are producing an immune response to this that we have to be concerned about suppressing. And so the food's important in terms of cross-reactivity, not right now.
Okay, and lose Dr. Corboy, perhaps. Okay. Dr. Alvarez, did you want to address the broader, somewhat related topic of diet for people who have suffered an immune-mediated attack?
I think I agree with all the comments I think that have been made so far. I think it's an area where you find a lot of evidence of one, meaning people describe how they manage their disease, and that works really well. I think the reality is that with most of the medications that we have, that we can control the immune system really pretty well. And I think we're left with sort of diets that, you know, are there for the overall health, right? So overall healthy diets, very colorful diets, you know, that kind of thing. There's a few things maybe with vitamin D supplementation that is coming that can kind of help regulate the immune system. And about every 1 or 2 years, I think you do find some other supplements that, again, with very little data, are suggestive that an MS, for example, or other immune conditions might be helpful. Turmeric or things like this are kind of the latest. But again, there are a lot of times very, very little evidence to help support that.
Okay. Yes, ma'am.
Hi, my name is Joanne Hicks, and this is my husband, Stephen Hicks. He has NMO spectrum disorder, every classic symptom that you could have. He was diagnosed in 2006. We're from the Springs. But on the onset of his illness. With him, started with a rash, a cough. He ended up becoming paralyzed, virtually overnight. I noticed with the neurologist in the Springs that none of them had any idea what was going on. And as a registered nurse, I had to do research. And then I came across the NMO. And so he tested positive with the aquaporin 4 and the IgG. They had him on methylprednisone at the onset, and he was progressively getting worse. They did the plasma exchange. He started getting better, but somehow the port was pulled out after, I think, like the third course of plasma exchange, and he relapsed. And at that time is when he got optic neuritis and had went blind. And that's when I knew that it wasn't just transverse myelitis, it was probably the NMO. And so he went back on the plasma exchange. The optic neuritis cleared up. He got feeling and sensation back in his hands. He was able to be weaned off the vent, but he's like at the nipple line down, and that's where it's been for the past 10 years. At that point, we had him put on Rituxan, which he's been doing for the past 10 years. And what I wanted to know is, should we continue? Are there studies that we should continue with the Rituxan forever? And since it's been 10 years, what are the odds of a relapse? Because when I researched this when he first got sick, it was like 5 years, and they said that you were probably going to be relapse free, but it's been 10 years and we're just afraid to take him off of the Rituxan because he has been pretty much relapse free for the past 10 years.
Okay, I'll turn that one to Dr. Bennett as well.
Wow. A lot of information there, and sounds like he and your family have been through a lot. I congratulate you on your own research, because in 2006, that was a year before even formal commercial testing for the antibody was available. It was just about in 2006 that it came out. 2004 was the actual original paper for the publication of the antibody. So you had to be up on your literature searches and curious and persistent enough to do it. And I'm glad you found out quickly enough, because likely from what you did, you limited the amount of damage. And two things that are important here. Number one is that neuromyelitis optica is an attack-mediated disorder. Unlike many other disorders, particularly, let's say, multiple sclerosis, what you see is what you get. So if you're not having an attack, there is no evidence that there's any progressive damage going on. So what you're doing with the Rituxan is lowering that risk, as far as we can understand it, of the next attack. Now, this is where your lack of knowledge and our lack of knowledge start to converge, and that is, how long does this have to go on? And unfortunately, just like in many other diseases, we have no great biomarker right now that we can test that says, okay, we've tested and now he's seen enough therapy that we don't have to put him at risk for any untoward infections or anything else that might come down the road with rituximab. It's fantastic that he's been on 10 years without any problems, because just like we've done for many other patients we treat with B-cell depleting therapies, and that's what rituximab is, we've seen great results when it's given as a single agent in terms of its safety, and there isn't any new data to suggest that he's at a new risk for being on for as long as 10 years. The only piece of data that we have for neuromyelitis optica in terms of risk of relapse is the presence of the antibody. And if you have an antibody present, and again, the data has not been redone with larger numbers of patients after therapy, but in the pre-therapeutic era, the risk of a relapse within the next year is 63% if you're antibody positive and untreated, okay? And the clock wouldn't start really on that risk perhaps with rituximab if you were to stop it, because it would take at least 6 months for his immune system to start to reset after being let go from the persistent depletion. But if his antibodies were still there, you would have to say that the risk, as far as we would understand, would come back to what it was beforehand. And so when I hear this question, which is the most common question that I encounter taking care of NMO patients, when can I stop taking this medicine? I give this same answer and say, I'll check for antibodies. If the antibodies are absent, I think you have the opportunity to stop and watch that test closely, repeating the antibody test at least every 6 months. And if the antibodies return, I would get back on therapy. Not everyone who's on rituximab loses their antibody titer whatsoever, but a fraction of NMO patients do. And in that fraction, I would say it's okay to come off therapy. Are there probably others that might be good, because we know patients can have plenty of antibodies circulating around on therapy and not have attacks. We don't understand necessarily what triggers an attack right now, but that would be the one thing that you could do to check whether it's okay. If they're still present, I would argue on the sense of safety to keep the treatment ongoing until we have more information about what other things we might do with rituximab that might reset the immune system and make it necessarily safer to come off of therapy because we've, hit the reboot button and things are back to normal.
Okay, thank you, Dr. Bennett. All right, I see another question over here, the woman in the blue shirt. Oh, all right, you'll be number 2. All right, sir.
Got it. Okay. Hi, Teri and Ericka from Washington, D.C. I'm really glad to be here. Just a quick question. I was diagnosed with transverse myelitis strictly on elimination of everything else. Took about 6 weeks. My MRIs are completely clear, except for some age-related spinal stenosis. Pathogens, deficiencies, everything negative, except for slightly low copper, but everything else. I was just curious, do you see patients who have no lesions at all on their MRIs? Just wondering, because on these online support groups I'm on, everybody says, well, where are your lesions? And I said, well, there are no visible lesions. I'm sure there's something there, but just any feedback on that. And the second question, real quick, you don't have to address this now, but from a rehab point of view, my main symptom is the banding here on my flank. And if there's any rehab or exercises or anything I could be doing to treat that, that's what bugs me the most. I could live with the other stuff. So, thank you.
Okay, I think that is a difficult question, what to do with transverse myelitis when the MRI is negative. Dr. Miravalle, do you want to try that one?
Well, yeah, thank you for giving me the difficult question. So we were just talking with Jeff here when you were describing your story, which unfortunately is not uncommon. We do see that patients present with a clinical syndrome, meaning the symptoms and the signs on physical examination, and yet when we do testing, when we do MRIs, we can't identify the lesion that actually accounts for those problems. And those are perhaps the most challenging situations in which you have to clinically define the syndrome, in this case, a spinal cord disease, and then the term transverse myelitis is implying 2 things. One, that there is a lesion or there is something that actually you can see in the spinal cord, and the myelitis portion of the term implies inflammation. So without those 2 evidence of those 2 terms, it's hard to actually put a definite seal to the diagnosis of transverse myelitis. So often when we see those situations, and after you ruled out any extensive list of possible situations that could account for that it seems like you had, you're left with treating the symptoms, if there is any residual deficits, if there is any pain associated with that, or anything that could have left after the event. And then keep a close eye on surveillance for anything else happening in the future, in which MRI is a very important tool to look at what we call dissemination in time, meaning new lesions occurring over time or new hints of pathology that actually suggest more of a chronic ongoing problem as opposed to a single event, monophasic event, that perhaps was associated with, and that's the classic quote that we say in medicine when we don't know what is going on, a virus or something metabolic, some side effect of a medication, something environmental yet to be determined that actually causes symptoms. So basically, when we approach these situations, one of the challenges that we have to sort out is this a one-time thing, a one event, a single event that actually will not recur, or this is the presentation of something that will continue to progress over time? So that's pretty much the question that we need to answer. And unfortunately, one of the most powerful tools that we have in medicine is one of the most difficult ones for patients to accept, which is time. And time is that one tool that will allow you to better determine what is happening. And I can only imagine how much anxiety one can go with once you have symptoms and problems, and all we tell you is to give us time, because that's something that, of course, you're going to go through with a lot of anxiety of not knowing what is happening. But time in these situations certainly helps to better determine the course.
Okay, great. And Janet, may I ask you to address maybe the band now or later?
I don't have any specific rehabilitation techniques necessarily, but sometimes doing some desensitization work with occupational therapists, and then medication management. And I think there's going to be a talk later on this afternoon about that. And then I'll talk more just about being active and trying to be active and healthy. Certainly always is helpful.
Other questions? Oh, yes, right over here.
Hi, my name is Lauren Duncan, and I have adult onset ADEM. And my questions is sort of two-part. One, I've seen 6 different neurologists in 2 different states. We've moved in the middle of this. And 3 of them denied I had ADEM in spite of the evidence on the MRIs, the spinal taps and everything, because adults don't get ADEM. And I have 2 questions with this. How do we change the classification to the doctors, the insurance, and Social Security disability that adults do get it and that it is a traumatic brain injury? Because we had to do quite a bit of petitioning for me to get cognitive therapy because I didn't have brain injury. Those are my 2 questions. Thanks.
Okay, I think that's a really a great question and a tough position to be in, right? I've already discussed that ADEM is a rare disorder. So when it's a rare disorder in children, where it's more common, that's different than a rare disorder in a rare population as well. And so do any of my panelists want to discuss some of the issues about how to sort of increase awareness that ADEM occurs in adults? And, you know, I think in a sense, we also feel sort of powerless to influence what insurance companies do, but if anybody has any thoughts on that topic as well.
And neurologists. Having neurologists tell you, I actually had one recently say, I don't have ADEM, I have sleep apnea. So that's a whole different ballgame right there we don't talk about.
Okay. All right, and it's tough not to get into specifics, but Enrique, do you want to take that one?
Sure. So I think I've definitely have seen ADEM in adults. So I guess I'm a believer. I think it can differ a little bit from pediatric ADEM. I think probably Teri, being pediatrician, sees probably 10 times as much ADEM as we probably do on the adult side. Sometimes a lot of the ADEMs that I've seen have been sort of a stepping stone towards MS and later become MS as well. And so kind of highlighting a little bit that diagnosis can change with time, and kind of the requirement for kind of monitoring in the patients that Dr. Miravalle was kind of describing as well. one of the hallmarks for ADEM being the confusion part of it, I think becomes something that as we learn a little bit about the conditions, it's still ingrained in the definition. I think it's less clear that adults get the confusion part of it. It becomes kind of a distinguishing hallmark with MS, and I think sometimes pediatric or kiddos with MS can have some confusion as well. And so I think it's an area distinguishing the two that's very important because the diagnosis kind of drives whether you're going to treat long term or not, but that we still have sort of a lot to go with, especially with the first question of trying to predict who's going to go on to have more events. And sometimes the name is just a name. What you're trying to kind of really determine is how chronic something will be to try and decide if you're going to treat long term. So I think the names can be a little bit malleable from that perspective. As far as the cognitive question, I think, whether I think the diagnosis becomes a little bit less important. I think if there's cognitive issues, you do cognitive therapy. And I think you can, again, it's a name, so you kind of push for what you need to try and get.
Hi, my name is Lois, and I was diagnosed in 2000 with TM. It started with weakness in my legs, flu-like symptoms, and extreme pain in the T3 and T5 dermatomes. I was working at the hospital, and they decided that I did have shingles, actually, which I believe was the cause of this. It seemed like I recovered, and now 16 years later, I feel like it's degenerative, and that's what my question is. The neuropathy that I had in those dermatomes is now moving up and down my left side. The banding is getting extremely worse, where I have moments where I can't even get air in or out, and it's really terrifying to not be able to breathe. So my question is this really TM if it's getting worse, in my opinion?
So the analogy that I use, I think, a lot of times for transverse myelitis is that it's a really broad term. It's kind of like saying you have a headache. And you can have a headache because you have migraines or because, somebody hits you over the head. And so it kind of describes a little bit what it is, but it doesn't tell you what caused it. And sort of the list of things that can give you transverse myelitis is probably 100 lists long. Anything that affects and gives you inflammation of the spinal cord, by definition, is just a transverse myelitis. And that can be sort of one-time events from viral infections, or it could be recurrent chronic things, and you can have a transverse myelitis associated with MS, with NMO, and with other kind of conditions. You can almost basically say that even if you have a slipped disc and it's putting pressure on the spinal cord, that it's a transverse myelitis. Now, it'd be secondary. You have the inflammation from something else. The surprising part a little bit would be from a shingles part from my end is to sort of say that it has kind of a progressive course a little bit from a past viral infection. And I think that would be sort of what you need to evaluate, is to try and see if it's ongoing infection or what the cause is, or has it become something else. Like we keep saying with a lot of these diagnoses, I think you have to constantly reevaluate. And just because it started one way, did it become something else?
I'll add one other thing, and it certainly sounds from what you described that you had transverse myelitis, that you had acute onset, obviously, of spinal cord symptoms, and now it appears that things are slowly getting worse, some of which involve the symptoms that you experienced abruptly with the onset of the transverse myelitis. And I think the two questions that any physician has to ask at this point is this one problem, that is, you had something that abruptly started and now is progressively getting worse, And the interval, obviously, between then and now, 12 years, makes me feel unlikely that this is one process, but potentially two. And, you know, every patient is allowed to have two things in their shopping basket during their lifetime, even though we try to coordinate it as one. And the idea is to keep it as simple as possible, given some of the symptoms overlap. But there's many other issues that could be going on that are making this old problem get worse, either symptomatically or even physiologically. So looking for other processes that affect the nervous system that could amplify what you previously got damaged in. Because often the nervous system, once something else goes on, will show its weakest link. And then the other problem is this something that is potentially just decompensating? That is, often we think about partial damage, complete damage. There's some part of the spinal cord that was wiped out. There's other parts that was barely holding on. And as we all age, we lose brain cells, and that is often unnoticeable because you have a lot of reserve. But when you don't have reserve because of an abrupt injury, that gradual loss can become more noticeable. So all those things have to be differentiated. But the big answer to your question, did you have transverse myelitis? Yes. The question is, what else is going on now?
How about over here, the woman with the striped shirt?
Hi, my name is Barbara Ellis. I'm from Austin, Texas. I have post-vaccination transverse myelitis following a yellow fever vaccine that was given to me at the age of 62 in June of 2014. I'm one of those people that you probably say are completely recovered, but what I'm left with is a lot of sensory deprivation, pain, weakness, bladder and bowel problems. But my area of interest is what is being done to promote, or what can be done to promote myelin repair, if anything. I imagine that Janet Dean, you might work with Dr. Becker at Johns Hopkins. I heard him speak about E-stim as a mechanism for repairing the spinal cord. And I'm also interested, I follow the HSCT stem cell work that's going on in Mexico. I know there's clinical trials here, but I'm interested in, and I know that that's not appropriate necessarily for people with transverse myelitis, that the use of chemotherapy to out your immune system and reboot it. But so my questions are, has there been any progress with E-stim to establish that it may help with myelin repair, and what is the prognosis for stem cell therapies for people with transverse myelitis as a means of trying to deal with the aftermath of a TM attack?
Okay, maybe Janet, shall we maybe assign you the first part, and then Augusto, do you feel like you can address a regeneration? Okay.
So I think sensory issues are a lot more difficult to treat with electrical stimulation. I think there is, probably some small evidence that doing some activity and getting signals going through your spinal cord can help to direct any possibility, of remyelination. But usually the E-stim is used if you can't move that part of your body, to be able to try and get some signals through your nervous system, not so much for specifically targeting sensory issues. But people that have incomplete myelination tend to be the ones that have the more trouble with things like pain and spasticity. So because signals are getting right. So I don't really have any, I'm not a scientist, so I can't really address that kind of issue very well.
And just to expand on that, you just brought me memories. One of my first works as a neurology resident was in a case of acute disseminated encephalomyelitis post-yellow fever vaccine. And we published that in some sort of obscure journal in Brazil. But the truth is that I learned a lot from that, and that's one of the cases that got me interested in looking at the interplay between infections and the immune system and the central nervous system. And what I learned from that is actually the mechanism for post-vaccination encephalomyelitis, or myelitis in your case, it's not that different to what you get in post-viral syndromes, in which your immune system somehow is exposed to something different. In your case, maybe a protein or some sort of component on the vaccine, in yellow fever vaccine. And that antigen that we call it in immunology somehow confuses the immune system for those cells to respond to anything that looks like that. And you will develop those memory cells that their only function in life is to go after anything that looks like that. And if for some odd reason the proteins or the antigens present in the vaccine mimic or they're similar to the antigens present in some sort of myelin cell or myelin-producing cell or any cell in your nervous system, there's going to be a cross-reactivity between those autoreactive cells now and your brain cells or spinal cord cells. So that is the basis that is thought to be behind the post-vaccinal encephalomyelitis or myelitis in your case. For the most part, those are monophasic syndromes. For the most part, those are things that happens once. And unless you're exposed to the same antigen again, you shouldn't have that again. So in your situation, you're dealing with a remyelination that happens in the context of a single event, as opposed to remyelination that happens in the context of a chronic progressive disorder like multiple sclerosis or multiphasic disorders like NMO, in which it's much more of a complex environment. So nothing has been done in monophasic disorders, at least that I'm aware, for remyelination, simply because of the challenges of understanding once the insult is gone, you're then dealing with a pseudo-normal stage in which you have the residual deficits from the lesion that occurred before, but the pathology itself is not progressing. Having said that, in the field of MS, it's perhaps one of the most active areas in which remyelinating therapies are being explored. And as you mentioned, there are many approaches that you can go. One is remyelination in the context of pathology, and there are antigens to antibodies to certain proteins that are being studied. And paradoxically, one of the first trials in humans was in transverse myelitis for anti-lingo therapies. And also situations that actually are making us learn from remyelination that not only medications may help with remyelination, and was explained before, exercise, physical therapy may help as well to enhance normal mechanisms for repair. So I hope Yes, so stem cells are being studied for MS and other chronic conditions, nothing for monophasic disorders.
I'll make a comment about stem cells, if that's all right. I think stem cells is one of those things that proves that for the right price, you can get somebody to do just about anything. And so there's a lot of clinics that have set up shop that claim to suck out some sort of cell, treat it with some kind of chemicals, and put them back into you to get stem cells. And one of the mental exercises I like to run through patients a little bit is if and this comes a little bit, so I did some stem cell work during my grad school years, was if it was easy for stem cells to take over a disease, we would have a cure for something like diabetes. All it has to do, those cells, would be identify how much sugar you have and pump out insulin. And those cells could be anywhere in your body as long as they're in the bloodstream, and just that's all they do. You could put any kind of cell, and as long as they can do that and pump out insulin, you should be able to take care of diabetes. And we don't have that yet. In the nervous system, you're asking to kind of squirt some cells, make sure they go to the right place. So if they end up at T1, that's not good. You want them to end up at the right place. Then they have to figure out what kind of cell there is. And there's over probably 1,000 different types of nerve cells and support cells in the nervous system that were damaged and that you want them to kind of become. Then they have to figure out and put all the connections downstream to where those cells were connecting to. And then they have to put out sort of the chemicals to communicate with the right cells, meaning that if that cell was going down to your right toes, you don't want them going down to your left toes. And so we're asking a lot when we're asking about stem cells in the nervous system. And I think we might get there, but I don't think it's going to be anytime soon. And I think if you're doing stem cells, you should look at doing it within a clinical study. Because for something with such little amount of data, paying $25,000 to $50,000, which is about the going rate, is a lot of money. How much? 54,000. All right. I guess inflation is affecting the stem cell industry as well. That you're asking sort of very little evidence to be paying that much money.
Okay, great. And I think there's another question in the back.
Hi, my name is Stephen Hicks Jr. You met my wife earlier. These are my daughters, Midori and Adriana. So my first question would be, and I've asked my wife about this, it was the first thing I asked when I woke up in the hospital, is transverse or neuromyelitis optica in any way hereditary?
Okay.
My next question would be is, why are neurology students still not learning about these diseases? Because I just saw my neurologist a couple weeks ago. He had a student sitting in the class, and she was Googling NMO while we were talking. She had never heard of it. Does the altitude have anything to do with these illnesses? Because I've started seeing a lot of people coming down with it in Colorado. And also, as you see, I look like I should just be able to get out of this chair and walk away. I was 380 pounds when I got sick. I weigh about 260 now. Is there any type of exercises that anyone in a wheelchair has come up with that I can do so I could lose some weight and lean up so I can help my wife? She's a foot shorter than me, and I outweigh by about 200 pounds. So, and she's throwing me all over the place. I need to lose some weight, but I have no clue how. Is there anybody that can help me? And what is the newest stuff for pain? Because I am sick of being in pain every second of the day.
Okay, that was a lot of really great questions. I'm going to try and summarize, and then we'll hit them one by one. So one is there any hereditary basis for NMO? And I think we can answer that pretty succinctly. I'll let Dr. Bennett do that. Next was about exercises that you can do in your chair to become stronger so that you can assist with some of your transfers and such. And then I heard a question about what can we do about pain. Pain is a real symptom in transverse myelitis. It's a beast sometimes to treat. And thankfully, we have a whole session on that this afternoon with Dr. Miravalle. And I might have missed another question in there.
Why aren't neurology students being taught about NMO and transverse myelitis?
Oh, okay. All right. Why does it seem that that medical students are not learning enough about these rare disorders? Is that right? Okay. Why don't we take that one first? Okay. So the extent of information that is conveyed in medical school is huge. It is just like drinking from a fire hydrant, the kind of information that comes at you. My hunch, though I don't know every medical school in the country, I know this one, is that these students are being taught about rare disorders, but it's hard to keep your eye on rare disorders when much bigger, more prevalent disorders like hypertension and congestive heart disease and other much, much more common disorders are sort of coming at you and being reinforced in the clinic and hospital setting repeatedly. Now, that being said, you only have to see it once. So I think that the students will have heard of this. It's in there somewhere. They may not remember NMO every day of the week, probably not. But the first time they see a patient with NMO, they're going to be like, I got it. Now I know what to look for. And what we as educators can do is to help them to recognize the patterns, to say, oh, hey, this gentleman has a transverse myelitis. He's just had an optic neuritis. There's something I remember. I need to go back to the book and think about what that could be. And that's something that we hope to do as neuroimmunologists and strive to do really every day of the week with medical students in our clinic. And I know that's happening elsewhere. But the Transverse Myelitis Association is helping to facilitate that by funding fellows, so doctors who have already had a certain amount of training who really want to know more about this in particular. And then once those fellows are trained, they can go out to an area that may not have a neuroimmunologist and really be that person to look for the patterns and to educate others.
Teri, I'm going to make a little comment here wearing my medical education hat. As Teri mentioned before, the field of medicine is expanding rapidly. And what med schools are trying to do is shifting from a knowledge-based curriculum, meaning we teach you everything we know, to a competence-based curriculum. We teach you how to be a good doctor, right? So which are competencies that are more difficult to actually accomplish, regardless of the knowledge base. So God forbid you ask me any questions on OB or gynecology. I don't remember, and I don't know that. And it's okay to say I don't know. And that's one of the things that we try to teach students nowadays. So don't confuse. Don't think that because your doctor doesn't know about NMO is a bad doctor, because we don't know anything in medicine. It's good to recognize who to see and build trust with your physician, and actually choose one physician that actually knows about what you have. But don't make the assumption that because they don't know, they're bad physicians, because the field of medicine is expanding very rapidly.
Okay. Dr. Bennett, do you want to address the question of whether or not neuromyelitis optica has a genetic basis?
I think in terms of what you're worried about, in terms of are you going to pass down a gene to your children that's going to make them have neuromyelitis optica, the answer is no. And there is no strong genetic link in this disorder. We've even looked at variants of the aquaporin 4 water channel and whether mutations in that gene can be passed on, and the answer is no. And so far, since the disease has really taken a focus in terms of medical investigation, and they're talking about an exponential increase in publications of neuromyelitis optica cases, there's probably been 6 families that have had multiple people affected by the disease. And I think similar to MS, yes, there are going to be certain genes that have an influence on the likelihood that you would present with neuromyelitis optica given the appropriate stimulation that happens to the immune system and makes it go awry. But those genes might be very minimal in terms of their influence, maybe a 2-fold, 3-fold risk, but nothing like passing it down genetically. With regard to altitude, which was your second question, nothing that's worrisome in terms of altitude and its effect on you, nor in terms of increased risk. I think why you're seeing more people that you know have been diagnosed with it is because of the other thing you're worried about. Awareness has increased enough that physicians are now doing the test. And sometimes it's appropriate, and sometimes I see patients where say, well, my neuromyelitis optica test was negative. And I say, well, that's no surprise. You have nothing that would have told me you would have even had neuromyelitis optica. But so sometimes the test is applied inappropriately, but I think in certain circumstances, physicians are learning to do the test, and that's been making the capture. When we originally described the disorder and started working on it, we would say it was 1/100th of the incidence of multiple sclerosis. We now appreciate that it's probably about 1/20th. So just by doing the test, we've learned that it's multiple times more common than we thought it was before.
Maybe now would be a good time to put in a plug. I've seen Elaine around somewhere. We have someone here from our research pool who is available if you want to find her during the break or during lunch to talk about some of the research that we are involved in here at the U. And
Lane has a table out in the hallway.
Perfect. Okay. Could we potentially save the question of exercises to be done in a chair for Janet Dean when she gives her discussion on rehab? Okay, wonderful. Are there other questions?
Hello, I'm Becky Gronenthal. I'm from the Atlanta area. I was originally diagnosed with idiopathic transverse myelitis in 2007. That followed a hepatitis B vaccine, which I'd had 4 days earlier. It was my second Hep B vaccine. Since then, I pretty well recovered from the TM for several years. I'm beginning to have some other symptoms now that I'm curious if they're related to this. About 2 years ago, my neurologist changed my diagnosis to ADEM, and I don't remember why. I did not originally have the confusion that's been described with ADEM. My first symptom was a very severe backache that went on for about a week before I went to the doctor. I was given oral methylprednisone, which seemed to make it better, but then a month later it came back worse than it was in the beginning, and I ended up in the hospital. Couldn't walk, couldn't urinate, had double vision for several days. I guess my main question is I'm concerned about vaccines. I've been told to never get another vaccine. And we have some new babies in our family, and I'm reluctant to hold the babies. I've been seeing commercials about whooping cough on TV. You know, I don't want to give my new baby in my family whooping cough. So is there any new information about receiving vaccines after this type of thing? My second question, you sort of just spoke about. I'm willing to offer up my body and my records. I just wonder if there are any studies going on. I've heard frustration from other people here that many neurologists don't seem to be able to tell me where to go from here. I'll mention one more thing. I have a blind spot in my vision in one eye, and I have a hearing loss in one ear. Not a complete hearing loss, but no one seems to really know if these things are associated with my original diagnosis. So any information you could give me on that would be appreciated.
Okay, well, with that additional piece of information, I wonder if your diagnosis was changed after the fact because of the suspicion that maybe it wasn't just something going on in the spinal cord, but maybe something a little bit higher in your brain as well that has affected your vision and your hearing. And we can maybe talk a little bit more about that offline. The question you bring up about vaccines is a really tricky one. And Augusto and I wrote a chapter a couple of years ago about this, so I'll turn it to him in a second. But I will say this is something that there is a lot of interest in. There is a lot of case reports, just like yours, having had a vaccine, and then within a couple days, within a few weeks, having had something like TM or ADEM. What we don't know for sure really is the incidence. Just how often does that happen? And is there any way to prove it? This is difficult because things happen temporally, at the same time all the time, but it doesn't necessarily mean that one causes the other. And so what we need as a medical community is to study that a little bit more to be able to say definitively, yes, that was related, or no, it wasn't. Maybe I'll pause right there and let Augusto jump in.
Yes, it's a complex field, and what we explained before with the yellow fever vaccine is a similar concept with Hep B or any type of vaccine. something to understand is that it's not that the vaccine did that to you. It's not that the presence of the virus or whatever it was inside the vaccine did that to you. It's how your immune system responded against that caused the transverse myelitis in your case. So could have been a vaccine, could have been just a simple spontaneous exposure to a viral particle for whatever other reason. So when we worked with Teri about this chapter on neurological complications of vaccinations, it became clear that after what you reviewed is single cases of just random development of autoimmune or immune-mediated syndromes. Could be ADEM-like, could be transverse myelitis, or could be any other combination of lesions elsewhere. And the recommendation from the CDC is that those cases are real, likely secondary to the vaccination, but the benefit of the vaccination still outweighs the risk of a potential autoimmune response after the vaccination. So the recommendation is still, despite the fact that you had a single event after a vaccine, if you need to have vaccinations in the future, you should proceed with those. A more complex question is, do you proceed with the same vaccine that you had before? Well, that's tricky. So if you had a response against yellow fever vaccine, would you have another vaccination with the same? I personally wouldn't, but the likelihood of cross-reactivity with other types of vaccines is very low. So the fact that that happened to you with a hepatitis B vaccine shouldn't preclude you from having other types of vaccinations.
Do we have any final questions before we take a quick break? All right, I see a couple hands. How about you, sir?
My name is Mark Stevens. I'm here from Southern California. I have NMO, and I'm treated with Rituxan. I understand there's a new drug coming in the pipeline for NMO that's similar to Rituxan. I'm just wondering what you know about it, what your thoughts are, if you are encouraged by it, what's the timeline for it. Just curious what you know about it.
Actually, I have several drugs that are being tested. I think I know which one you're talking about, but I'll let Dr. Bennett address that.
Yeah, so with regard to NMO therapy, there are no, quote, approved therapies for NMO. There are things we use that we think have benefit, and one of the more potent ones is the B-cell depleting therapy, rituximab, which targets a molecule on the surface of B cells, which is CD20. And not all B cells have this marker on their surface, but a significant fraction of them do, and that results in a marked depletion of circulating B cells in the body, although there are B cells still living in your marrow and other lymphoid organs in which the drug is not going to penetrate. With that being said, this lack of therapy in NMO has led to the initiation of 3 phase 3 clinical trials that are going on at the present time to look for preventative therapies and prove their benefit for the treatment of this disorder. The one you're thinking of is called MEDI551. It also just got a name from the FDA, Adavolimab. We joked that it was unpronounceable, is what its true name was. But MEDI551 is a B-cell depleting therapy that is in clinical trials. We're doing the trial here at the University of Colorado. It is an anti-CD19 antibody. And the difference between CD19 and CD20 is that CD19 affects a broader group of B cells in the body, so the depletion could effectively be broader, in particular for those B cells that produce antibodies. Once B cells become professional antibody-producing cells, they lose the expression of CD20, but they continue with the expression of CD19, except when they get to their final level of differentiation. So the idea is that this drug may, in particular, deplete those cells that are just becoming antibody-secreting cells, so they're plasmablasts, and that it may ultimately help reduce the titers of aquaporin 4 antibody in affected patients that we don't see universally at all amongst rituximab-treated patients. Also, there's another thought that anti-CD19 is expressed in B cells that are developing in the bone marrow much earlier than CD20 comes on. So the idea is with penetration into the bone marrow, it may deplete these autoimmune B cells that would normally be surviving there, and then hence lead to a more durable depletion that could ultimately lead to being able to stop the drug. With all that said and done, it's about 50% enrollment. That is, I think we hit the first 100 patients. There's about 220 that were expected to be necessary to enroll in the trial to see a final result. So we're halfway there. This is an international trial. And I had the opportunity to design some of it and participate in a lot of the education across the world for investigators in it. And I think it has a lot of promise. The other two trials, an anti-IL-6 receptor medication. It's a different variety, is marketed in the U.S. under the name tocilizumab, and it is a different souped-up molecule, so to speak, that's being used in the trials for NMO by Chugai is the company sponsoring the trial, and this is an SA237 molecule is what it's called right now. But this compound, in used off-label, has shown some promise in patients resistant to CD20 depletion with rituximab. And then finally, eculizumab, which is currently approved for a single disorder, acute paroxysmal nocturnal hemoglobinuria, which is patients that break up all their red blood cells often at night. This is a complement-mediated disorder, and this is an anti-complement therapy that in a phase 2 trial of 14 patients with refractory NMO showed a benefit, and we know complement plays an important role in acute onset of therapy. So this trial is going on in the U.S. and internationally as well. Complement does a lot of other things, and including help to clear bacterial infections. And so with anti-complement therapy, there is a risk of meningococcal meningitis. Patients have to be vaccinated. And because your body makes a lot of complement, you have to receive therapy every 2 weeks to keep it down. But it showed promise in preliminary trials, and that's ongoing. So 3 phase 3 trials going on. We're participating in 2 of them here, the Chugai one and the MedImmune one that I mentioned. So we have opportunities for patients who might be failing one type of therapy or another or never even had therapy before. So there's plenty of interest in a rare disorder, so there can be interest in therapy by drug companies in rare disorders. And we're hoping that, I think within, it's safe to say, resolution, summation of the trial, good results, FDA approval, we're looking at a formal therapy for NMO maybe in about 2.5, 3 years, I think is realistic.
Is there one more question? How about right here in front?
My name is Stephen Curtis. Our son was diagnosed with ADEM October of 2013, and we moved countries so that we could be closer to our doctor, Dr. Schreiner. So before I say anything, I just want to thank all of you for taking the time and the TM Association for making this possible. I have 2 questions. It seems doctors keep telling me that ADEM is gone or over, and I think you described it earlier, Dr. Bennett, kind of monolithic, but it doesn't feel like it's gone. And then my other one, and this may be anecdotal in your answer, is it feels like there's a lot of things going on, and so I wondered in some of your studies, whether it be with ADEM or TM or whatever, if you often see other things. For us, it was central sleep apnea, ADEM, and now hydrocephalus. Dr. Schreiner knows as well. So, but I just wondered, and I know this is anecdotal. I probably know there's no data because I was just told on Thursday there's no data. So I would just, if you're willing to, even just your opinion, if you start to see some of these things linked, and I don't know if it's true for some of the other diseases.
Okay, this is I'll address part of this, but then I will ask my colleagues for their opinion as well. So your first part was like, you tell me this is a monophasic disease. It doesn't feel monophasic. Like this is continuing and it's changing. I think what you are observing is what everybody sort of reports. Like things seem to get better in the acute phase in very measurable ways. My left leg didn't move. Now it moves. We consider that to be improvement, and it is. But what we don't quantify as well is the patient and the family's experience with that disorder as it progresses. We know that there's been an attack on the central nervous system, and the body has some ability to heal the central nervous system, but it's never quite the way it was before. And so going forward, there are commonly cognitive changes, behavior type changes, and as with any disease, TM, NMO, ADEM, AFM, there's fluctuation as well. And that's one thing that I think I'll ask my colleagues to comment on in a minute is about how they address the discussion about fluctuation, because we recognize commonly that when patients are sick, when they are fatigued, stressed, ill, feverish, that things can change, and they change in a way closer to what the patient looked like at the beginning of the episode. Now, I know your son, so I don't have a great answer for why he had this thing seemingly unrelated to ADEM and then ADM and now something else that is seemingly unrelated. So I'll ask my colleagues as well, in your experience, and maybe Dr. Qureshi, you can start. Have you seen a patient with ADEM who has had concurrently or previously post a hydrocephalus or obstructive sleep apnea or something that you tried to reconcile with the disorder of ADEM? Either yes or no.
I have not.
Okay. All right. Anybody else among my esteemed colleagues?
I think you can sense kind of the same question that's come up, I think, 2 or 3 times. And I think people give advice around what they're familiar with and what they're good at. When you see the neurologist, we think in the terms of sort of disease-modifying therapies, and we consider it a success once we control the inflammation. I think this is the big justification for doing these multidisciplinary clinics, because then we get to a point where we can't fix what's broken, and so we end up trying to work then with the rehab people or pain specialists or other groups to kind of then try to address sort of the issue of the damage that's been left behind. And we do, I think, a lot of times misspeak and kind of say, oh, okay, now you're better, you're controlled. And that doesn't necessarily mean you're good functionally, but sort of from the stuff that we kind of look at in our perspective, this is kind of what we're good at and can kind of work on. And I think that's kind of an important step, is to kind of look back and say, okay, who else do we need to get involved to try and kind of keep addressing these issues?
Maybe you can put a plug in for a new approach to medicine, whether it's through medical school, medical learning, or through patient care, which is patient-centered. And what we've been trying to do traditionally in medicine is determine certain disorders and try to fit that to a patient. And whenever that didn't fit naturally, we call it atypical. The push now is to try to forget about the labels first and see what is happening to you and try to learn from your experience, or from your son in this case experience, and try to use the tools that we have by knowing certain disorders and try to help you through that. But the patient is the center as opposed to the disease. And a lot of what you will see this is a classic example. You have a variety of disorders under one umbrella, which is rare neuroimmunological disorders. And we have certain labels that sometimes fit classically, but sometimes they don't. And then you end up with these spectrum disorders or these atypical presentations. But at the end, what matters is what happens to an individual patient. And so we use the terms, we use the labels, but I was alluded before, what matters is the patient, and what matters is having a team of individuals that actually might help your son as opposed to the disease.